Welcome to PRISM Rounds, the audio journal club where we break down one study at a time for ICU, ED, and pulmonary/critical care teams, physicians, trainees, nurses, pharmacists, and respiratory therapists. A quick note before we start, this episode is created using AI-generated voices. I originally made these episodes to support my own learning and review, and I'm sharing them publicly in case they're helpful to other busy clinicians and learners. Because the voices are synthetic, you may occasionally hear mispronunciations of medical terms, drug names, or author names. Thanks in advance for your patience. Everything you'll hear is for education only and not medical advice. Let's get into today's paper.
So, let's start with this scenario.
Okay.
It is 3 a.m. You are an intern, and the year is 2010.
Oh boy. A long time ago.
Yeah, right. So you have a patient in the ICU who is hypotensive. Their mean arterial pressure is hovering around 55, and they are just not responding to fluids. Your attending looks at you across the bed and asks, "What pressor do you want to start?"
Well, I mean, in 2026, that is a rhetorical question. You start norepinephrine.
Right.
Honestly, if you said dopamine today, the attending would probably check your own pulse to make sure you aren't having a stroke.
Exactly. But in 2010, that was actually a genuine debate.
It really was.
In fact, depending on where you trained and, who was on call that night, dopamine might have been the default answer.
Yeah.
There was this pervasive, almost cultural belief in the ICU that dopamine was the safer starter drug, and norepinephrine was like the heavy artillery that you only brought out when the patient was already 1 foot in the grave.
The old leave a fed, leave 'em dead adage.
Right. The classic rhyme. And today, we're going to deconstruct exactly why that adage died out.
It's about time.
We are doing a sort of retro rounds deep dive today. We actually had a request from a group of medical students who reached out.
Oh, that's great.
Yeah, they wanted to understand the actual evidence behind our current default practices. They basically asked, why is norepinephrine king?
It's a fantastic question because we take it for granted now.
We really do. So to answer that, we have to go back to March 4th, 2010, to the New England Journal of Medicine and the publication of the SOAP CHIP trial.
SOAP2. The sepsis occurrence in acutely ill patients trial.
That's the one.
I mean, it is, without exaggeration, one of the most significant critical care trials of the last 2 decades.
Yeah.
It essentially ended a 50-year debate in about 6 months.
So grab your stethoscopes and let's travel back to 2010. The mission today is to deeply analyze the head-to-head battle between dopamine and norepinephrine.
I'm ready.
We are going to break down the pharmacology that explains the clinical failure of dopamine. We are going to dissect the trial design that finally proved safety is a mortality equivalent. And we're going to look at the statistical nuance of subgroups that completely changed how we manage heart failure.
And we're going to do it with the clarity of hindsight. Because looking at this taper 16 years later, the results seem so obvious.
Right.
But I remember when this dropped. At the time, this was earth-shattering stuff.
Let's set the clinical stage first, though. We need to really understand the mindset of the 2010 intensivist. Why was there such hesitancy to use norepinephrine?
It was rooted in a misunderstanding of physiology versus outcome.
How so?
Well, norepinephrine is a very potent alpha-adrenergic agonist. It clamps down on blood vessels hard.
Yeah.
And the fear was that if you used it too early or too aggressively, you would vasoconstrict the renal arteries, the mesenteric arteries, and the peripheral vasculature so severely that you would actually cause ischemia.
The fear was basically that you would fix the blood pressure number on the monitor, but you would rot the kidneys and turn the fingers black in the process.
Precisely. It was viewed as just too strong, too harsh.
Right.
Meanwhile, dopamine was viewed as the gentleman's pressor.
The gentleman's pressor. I like that.
It was thought to be easier to titrate, and it had this alluring, almost magical property attributed to it, which was renal dose dopamine.
Oh, man, we have to talk about that.
We do.
The idea that low-dose dopamine, say 2 to 3 mics per kilo, would selectively dilate the renal arteries and somehow save the kidneys.
It was a theory that was biologically plausible on paper, but it has zero robust clinical evidence to support it.
None.
Yet it drove practice for decades.
Yeah.
So in 2010, you had this massive tension. You had the dopamine believers who thought they were protecting organs, and then you had the norepinephrine pragmatists who just wanted to get the MAP up.
And into this tension enters DeBacker and colleagues with SOAP. But before we even get to the trial protocol, I want to spend some real time on the pharmacology.
Let's do it.
Because the editorial by Gerald Levy that accompanied the trial, it's called Treating Shock Old Drugs, New Ideas. It makes a point that I think is often lost on students today.
Oh, the direct versus indirect action.
Exactly. He talks about the difference between direct and indirect acting agents.
This is the absolute crux of the physiological argument, and it perfectly explains why dopamine fails in the sickest patients.
Walk us through it.
Let's look at norepinephrine first. It is a direct agonist.
Meaning it brings its own lunch to the party.
Yeah, in a manner of speaking.
Mm.
Norepinephrine circulates in the blood and binds directly to the alpha-1 receptors on the vascular smooth muscle to cause that constriction.
Right.
It also binds directly to the beta-1 receptors on the cardiac myocytes to increase contractility.
Okay.
The key here is it does not rely on the patient's internal machinery to work. It is an exogenous key fitting perfectly into an endogenous lock.
Okay, so it's reliable. It works whether the patient is perfectly healthy or literally at death's door.
Exactly.
Now compare that to dopamine.
Dopamine is messy.
Messy how?
It's a precursor molecule. In the body's natural synthesis pathway, you make dopamine, which is then converted into norepinephrine inside the nerve terminals.
Right.
So when we give exogenous dopamine as a drug, yes, it hits some dopamine receptors. But a significant part of its vasopressor effect, the clamping down we actually want, comes from it being an indirect agent.
Explain indirect in the specific context for the listeners.
It means dopamine physically enters the sympathetic nerve terminals and displaces the norepinephrine that is already stored there. It forces that stored norepinephrine out into the synapse. It's effectively squeezing the sponge of the nerve terminal to release the body's own native norepinephrine.
And this is exactly where the empty tank theory comes in.
Exactly. Think about a patient with prolonged, severe septic shock.
Oh.
Their sympathetic nervous system has been firing at absolute maximum capacity for hours, maybe even days before they got to the ICU.
Right.
Those nerve terminals are severely depleted. The storage vesicles are empty. There is virtually no norepinephrine left in there to squeeze out.
So you are infusing dopamine, expecting a blood pressure response, but the entire mechanism relies on a biological supply that simply isn't there anymore.
Right. It's like whipping a tired horse.
Yeah.
You can whip it all you want, but if it has no energy left, it won't run faster. It might just collapse. Levy points this out brilliantly in the editorial.
He does.
He argues that in severe septic shock, relying on an indirect agent is just physiologically unsound from the jump.
Whereas norepinephrine is like hooking a completely fresh horse up to the wagon. It doesn't care if the old horse is tired.
That is the perfect analogy. And there's another whole layer to the pharmacology here, which is the receptor profile dirtiness.
Right, the lack of specificity.
Exactly. Norepinephrine is relatively clean, mostly alpha, some beta. Dopamine is all over the place, depending on the exact dose you give.
Ah, yes, the famous dose-dependent effects we all memorized for the boards. Low dose for kidneys, allegedly. Medium dose for the heart. High dose for pressure.
Right. But the inherent problem is patients don't read the textbooks.
We never do.
The overlap between those dose ranges in a real human body is huge. And crucially, dopamine has significant beta-adrenergic effects.
Meaning it stimulates the heart?
Yes. It drives heart rate chronotropy much, much harder than norepinephrine does at equivalent doses.
And if you have a patient who is already tachycardic because they're septic, they have a fever, they are volume depleted.
Yeah.
Driving the heart rate even higher with a drug artificially increases myocardial oxygen demand.
You are increasing MVO2, myocardial oxygen consumption.
Right.
You are asking the heart to do significantly more work at the exact moment the body is struggling to deliver adequate oxygen to the tissues. It creates a massive supply-demand mismatch that can easily lead to outright ischemia.
So theoretically, even before the SOAP2 trial enrolled a single patient, we had solid physiological reasons to suspect dopamine might be inferior.
We absolutely did.
It relies on depleted neurotransmitter stores, and it whips the heart unnecessarily.
Yes, but, biological plausibility has led us astray in medicine many, many times before.
That's true.
We needed a massive randomized controlled trial to actually prove it. And that brings us to the trial itself.
Let's break down the design of SOAP2. This was a multi-center, randomized, double-blind trial.
Yeah.
And I want to pause on that term, double-blind, Because I feel like we just glaze over that term nowadays.
They do.
We read a paper and say, oh, it's double-blind, cool. But in a vasopressor trial, blinding is a literal logistical nightmare.
It is incredibly difficult. Just think about it practically at the bedside.
Right.
You start the drug infusion. If the heart rate suddenly shoots up by 20 beats per minute, a savvy ICU clinician might immediately guess, oh, this is dopamine. Or if the pressure spikes beautifully with absolutely no heart rate change, they might guess norepinephrine.
Plus, the drugs literally look different in the vials. They come in different concentrations. They run at different rates. To effectively blind this, you need a highly dedicated team.
They had completely independent research staff preparing the infusions in the pharmacy.
Wow.
The clinical team standing at the bedside had absolutely no idea what was in the syringe they were hanging.
Which is vital.
It is vital because it eliminates what we call titration bias.
Okay, break down titration bias for the listeners.
So if I am the attending, and I know I am giving norepinephrine, and I strongly believe the leave-fed, leave-em-dead myth,
Right.
I might be very hesitant to titrate the drip up. I might actually underdose the patient because I'm terrified of causing ischemic side effects.
That makes sense.
Conversely, if I know it's dopamine, maybe I'm way more aggressive because I think it's gentler. Blinding forces the clinician to simply treat the blood pressure number on the screen, totally separated from their personal prejudice about the drug.
It's pure science at that point. And the scale of this thing was massive. 1,679 patients.
It was a monumental undertaking.
Truly.
For context, many ICU trials really struggle to get 200 or 300 patients. Getting almost 1,700 patients in shock across 8 different centers in Europe is just a massive achievement.
Yeah.
It gave the study the statistical power to actually detect small differences in mortality if they existed.
Let's talk about the inclusion criteria.
Yeah.
Who exactly were these patients?
They were adults with shock.
Yeah.
They defined shock as a mean arterial pressure, less than 70 millimeters of mercury, or a systolic less than 100, despite adequate fluid resuscitation.
Okay, stop right there. Adequate fluid resuscitation.
Oh, here we go.
This is one of the biggest controversies of the entire trial, especially looking back from our vantage point in 2026.
It absolutely is the main sticking point.
The trial protocol defined adequate fluid as at least 1,000 milliliters of crystalloids or 500 milliliters of colloids. Basically 1 liter.
1 liter.
If I have a patient in floored septic shock today and I decide to start pressors after giving only 1 single liter of fluid, my attending is going to give me an hour-long lecture on volume status.
They would.
The surviving sepsis guidelines typically recommend 30 cc's per kilo. For an average 70-kilo human, that's over 2 liters up front.
Right. And Dr. Levy specifically calls this out in his editorial.
He does.
He notes that 1 liter is a relatively low amount of fluid for these sick patients. This implies that many patients in this trial might have actually been significantly hypovolemic when they started the study drug.
And why does that matter so much for the direct comparison between the 2 drugs?
Because hypovolemia heavily exacerbates the side effects of any vasopressor.
Okay.
If the vascular tank is empty, you have to squeeze the vessels that much harder to maintain a pressure.
Right.
That means you have to use much higher doses of the drug. And with dopamine, higher doses directly translate to more beta stimulation, more tachycardia, and consequently more arrhythmias.
So one major critique could be that this wasn't just a trial of dopamine versus norepinephrine in a vacuum. It was a trial of dopamine versus norepinephrine in a potentially under-resuscitated patient population.
That is a very valid critique. It is entirely possible that if everyone had properly received 3 or 4 liters of fluid, the difference between the adverse effects of the drugs would have been smaller.
Because the required doses would have been lower overall.
Exactly. But at the end of the day, we have to analyze the data we actually have.
Fair point.
Yeah.
And the mix of patients in the trial is really important too. It wasn't just a purely sepsis trial.
No, it wasn't. And this actually sets up the most dramatic finding of the entire study later on.
Let's hear the breakdown.
About 62% were in septic shock,
The majority of that.
but roughly 17% were in cardiogenic shock and 16% were in hypovolemic shock. They basically took all comers.
Which gives the study excellent external validity because it reflects the genuinely messy reality of the emergency department and the ICU. You don't always know exactly what kind of shock you're dealing with right at admission.
Exactly. You just have a hypotensive patient in front of you.
Right.
So they randomized them. Group A got dopamine. Group B got norepinephrine. They titrated the drip to maintain that target MAP, but they did have a strict ceiling.
Right, the dosing cap. Tell us about that.
Dopamine was capped at 20 micrograms per kilogram per minute.
Okay.
Norepinephrine was capped at 0.19 micrograms per kilogram per minute.
And what happened if the patient was still hypotensive at that cap? Did they just stay hypotensive?
No. If they hit the cap and were still crashing, the clinical team could add open-label norepinephrine.
Gotcha. Which is obviously an ethical necessity. You can't just let the patient die for the sake of strict protocol adherence.
Right.
But from a methodology standpoint, it does dilute the purity of the results a bit, right?
Right. It does. It means the dopamine group was really dopamine plus rescue norepinephrine for the absolute sickest patients in that cohort.
That's a great point. Okay, let's get to the meat of it, the results.
Let's do it.
The primary outcome was 28-day mortality. Did one drug ultimately save more lives than the other?
Well, if you just look at the raw unadjusted numbers, the dopamine group had a mortality rate of 52.5%.
Okay.
And the norepinephrine group was 48.5%.
So a 4% absolute risk reduction in favor of norepinephrine. Clinically, that sounds pretty good.
It does sound good, but we have to look closely at the actual statistics.
Right. The math.
The odds ratio was 1.17, but the 95% confidence interval crossed 1.0, and the p-value was 0.10.
0.10. So by the strict, rigorous rules of frequentist statistics, there was no statistically significant difference in mortality.
Correct.
It was technically a tie.
We cannot reject the null hypothesis here. We cannot say with statistical certainty that norepinephrine definitively reduces overall mortality compared to dopamine based solely on this primary outcome.
And I remember clearly when this paper came out, there were some diehard dopamine fans who seized on that. And they said, see, no difference. I can totally keep using my dopamine.
Oh, they definitely said that. But that position became completely indefensible when you actually turned the page and looked at the secondary outcomes.
The safety data.
Specifically, the arrhythmia signal.
This was the absolute nail in the coffin.
It really was. The study meticulously tracked adverse events, specifically looking at arrhythmias like atrial fibrillation, ventricular tachycardia, and ventricular fibrillation.
What were the final numbers on those?
In the dopamine group, 24.1% of patients experienced a significant arrhythmia.
Almost a quarter of them.
Right. In the norepinephrine group, it was only 12.4%.
That is basically double the rate of arrhythmias.
It is an odds ratio of roughly 2.3, and the p-value for this was less than 0.001.
Wow.
This wasn't some borderline questionable finding. This was a massive, highly significant signal of sheer harm.
And let's translate that math back to the bedside. We aren't just talking about a few benign PVCs popping up on the monitor.
No, we are not. The single most common arrhythmia observed was atrial fibrillation.
Right.
In a patient with profound shock, new onset AFib is an absolute disaster.
It really is.
You immediately lose the atrial kick, that extra 20 to 30% of active ventricular filling.
Which means your stroke volume tanks.
Exactly. So your cardiac output drops.
Yeah.
And your blood pressure, which we're already trying to support, drops even further.
So now you have created a massive new problem. You have to actively treat the complication your drug just caused. Do you try to cardiovert them? Do you load them with amiodarone? Do you try to rate control with a beta blocker?
Right.
But wait, their pressure is 60/40. You definitely can't give a beta blocker.
Exactly. It's a clinical nightmare. You are creating a new physiological problem that makes the original physiological problem so much harder to solve.
Yeah.
And the study perfectly reflected this bedside hassle factor. They specifically looked at how many patients had to completely stop the study drug because of these severe side effects.
The discontinuation rate.
Right. 52 patients in the dopamine group had to be forcibly withdrawn from the study drug due to serious life-threatening arrhythmias.
52.
Compare that to only 13 in the norepinephrine group.
That is exactly a 4-to-1 ratio. That represents 52 separate times a physician stood at the bedside, looked at the monitor, and said, this drug is actively harming my patient right now. I have to turn it off.
And that right there is exactly why I always tell students, safety is a primary clinical outcome.
Absolutely.
Even if the mortality p-value was 0.10, meaning a statistical tie. If drug A and drug B have the exact same survival rate, but drug A causes twice as many heart attacks or arrhythmias,
Right.
drug A is unequivocally the inferior drug, period.
It's essentially number needed to harm.
Effectively, yes. For every 8 or 9 patients you treated with dopamine, one would get a severe arrhythmia they simply wouldn't have had if you just used norepinephrine.
That is a terrible, terrible safety profile for a first-line agent.
It is.
I want to dig into a specific critique from the Levy editorial regarding the dosing. We mentioned the protocol caps earlier, 20 mics for dopamine versus 0.19 for norepinephrine. Levy brings up this concept of equipotency.
Ah, yes. This is a really sophisticated methodological point that often gets overlooked.
Break it down for us.
The whole study design fundamentally assumed that 20 micrograms of dopamine is roughly equal in pure pressor power to 0.19 micrograms of norepinephrine.
But is it actually equal?
Levy strongly argues there is virtually no solid evidence for that specific ratio. It was somewhat arbitrary based on historical practice.
Right.
His hypothesis is that 20 mics of dopamine is actually a massive, massive dose. It's a much higher physiological push than 0.19 of norepinephrine.
So in this trial, we might have been comparing a sledgehammer of dopamine to just a rubber mallet of norepinephrine.
Or at least a sledgehammer to a regular standard hammer.
Right.
If the dopamine dose was effectively much higher in terms of total adrenergic stimulation, that alone would easily explain the huge excess in arrhythmias. We were essentially overdosing the dopamine group relative to the norepinephrine group just to achieve the exact same MAP target.
That makes a lot of sense, but doesn't that inherently reinforce the final conclusion anyway?
What do you mean?
Well, if you actually need that massive arrhythmia-inducing dose of dopamine just to get the MAP up to 65, while a moderate, safe dose of norepinephrine does the exact same job smoothly, then dopamine is just fundamentally a bad drug for this purpose.
Exactly. That is the perfect takeaway. It highlights the incredibly narrow therapeutic index of dopamine.
Right.
The clinical window between working and wildly toxic is just very small. With norepinephrine, you have a huge safe range.
Yeah, we run norepinephrine at 0.5, 0.8, sometimes even 1.0 mics per kilo in extreme rescue cases.
And it remains relatively linear and predictable. Dopamine completely falls apart at the high end of the dose range.
Okay, so we have a technically neutral mortality signal overall, but a profoundly terrible safety signal for dopamine. Now we need to pivot and talk about the specific subgroup that actually did show a mortality difference.
The cardiogenic shock subgroup.
Right. This is the most controversial and arguably the single most important part of the paper for the cardiologists listening.
It absolutely is.
Remind us of the exact numbers here.
There were 280 patients total presenting with primary cardiogenic shock.
Okay.
When the authors analyzed just this specific subgroup, the mortality in the dopamine group was significantly higher than in the norepinephrine group. The p-value was 0.03.
No, wait. Let me play devil's advocate for a second, based on how I was taught back in the day.
Go for it.
Dopamine is fundamentally an inotrope. It increases cardiac contractility. Norepinephrine primarily increases afterload, meaning it makes the failing heart pump against a much higher resistance.
That was the exact conventional wisdom in 2005.
Right. The old teaching would have said, whatever you do, don't use norepinephrine in pure heart failure. You will completely crush the weak pump with all that afterload.
That was the widely held wisdom. But what SOAP2 showed us is that the physiology of ischemia strongly trumped the physiology of afterload.
Explain that mechanism.
In cardiogenic shock, the heart is already failing. It is heavily stressed, and it is often ischemic, meaning the tissue itself isn't getting enough oxygen.
Right.
Dopamine vigorously whips the heart. It drives the heart rate up. Tachycardia is the absolute worst enemy of the failing ischemic heart.
Because it wildly increases oxygen demand.
Yes. And worse, it drastically decreases the time available in diastole for the coronary arteries to actually fill with fresh blood.
So you are taking a heart that is already literally starving for oxygen, and you are chemically forcing it to run a sprint.
Exactly. It's a recipe for disaster. Whereas norepinephrine raises the overall blood pressure primarily by squeezing the peripheral vessels. Yes, it does increase afterload.
Right.
But by significantly raising the diastolic blood pressure, it simultaneously increases the perfusion pressure, driving blood into those coronary arteries.
Ah, so it actually feeds the heart.
It feeds the heart much more than it whips it. Dopamine whips the heart far more than it feeds it.
So the significantly higher mortality observed in the dopamine group was highly likely driven by unchecked cardiac ischemia and subsequent lethal arrhythmias.
That is the leading, most biologically sound theory.
Now we have to put on our methodologist hats for a second because there is a very tricky statistical caveat here that we really cannot ignore.
I was waiting for this, the interaction test.
The interaction test. This is exactly where the trial statisticians and the bedside clinicians get into a bar fight.
They really do.
Explain the concept of the interaction test to the listeners.
So when you do a subgroup analysis, like isolating and looking at just the cardiogenic shock patients out of the whole cohort,
Right.
you have to ask a statistical question.
Here.
Is the distinct difference we see in this specific subgroup statistically different from the overall result in the main study group? Or is it just random statistical noise bubbling up within the larger data set?
Meaning, did the actual fundamental drug effect truly flip in this population? Or did we just happen to get a cluster of really sick heart failure patients randomized to the dopamine arm by sheer chance?
Exactly. The test for interaction measures exactly this probability. In the SOAP2 data, the p-value for the interaction between the specific shock type and the treatment effect was 0.87.
0.87, that is huge. That means highly non-significant.
Extremely non-significant. Strictly statistically speaking, this completely prevents us from definitively claiming that dopamine behaves fundamentally differently in cardiogenic shock compared to septic shock. The methodologically pure, rigid interpretation is simply dopamine is likely equally bad for everyone, and that stark cardiogenic signal might just be random chance. But clinically, at the bedside, you simply cannot ignore it.
Right, because you have a stark Kaplan-Meier survival curve showing the dopamine patients dying at a visibly much faster rate.
Yes.
You have a predefined p-value of 0.03 for that specific isolated group. And you have a rock-solid, completely logical biological mechanism. Tachycardia induces ischemia to perfectly explain it.
Exactly. This is precisely where the art of evidence-based medicine actually requires human judgment.
Yeah.
Do you coldly ignore a very strong signal of severe clinical harm just because an interaction test was technically underpowered? Or do you protect your patient and act on the safety signal?
Well, the global medical community clearly voted with their feet on this one. After SOATT dropped, the use of dopamine for cardiogenic shock basically vanished overnight.
It absolutely did. The entire risk-benefit calculus shifted completely. If norepinephrine is demonstrably safer, with fewer arrhythmias, and potentially saves significantly more lives according to that cardiogenic signal, why in the world would you ever choose dopamine?
You just wouldn't. Now, there is one last bastion of dopamine defense we critically need to besiege before we wrap up.
The kidneys.
The zombie myth that just won't die.
It really won't.
Did the SOAP10 trial find absolutely any evidence whatsoever that dopamine protected renal function?
None. Absolutely zero.
Nothing at all.
Nothing. They looked at daily urine output. They looked at peak serum creatinine levels. They closely looked at the ultimate need for renal replacement therapy, meaning dialysis.
And more of the results.
No difference. The rate of patients eventually needing dialysis was statistically identical between the dopamine and the norepinephrine groups.
So the pervasive fear that norepinephrine aggressively clamps and kills the kidneys?
Completely debunked by the data.
And the magical hope that low-dose dopamine gently flushes and saves the kidneys?
Also entirely debunked.
It turns out the kidneys really just want blood pressure.
The kidneys are remarkably simple creatures at the end of the day. They just critically need a driving hydrostatic pressure to filter the blood.
Right.
If norepinephrine effectively provides that MAP of 65 or 70, the kidneys are perfectly happy. They honestly don't care that the afferent renal artery is slightly pharmacologically constricted as long as the total perfusion pressure pushing through is adequate.
It's honestly amazing how long that renal dose myth persisted in the culture of medicine. I genuinely still hear it occasionally from very, very senior consultants who initially trained back in the 80s.
It is incredibly hard to unlearn a deeply ingrained physiological concept you were taught during residency. But SOAP2 finally provided the definitive large-scale data to stand at the bedside and say, please stop doing this.
So bringing it all back to today, to 2026, if we are advising that medical student from the beginning of the show on rounds tomorrow, how do we succinctly summarize SOAP2? What are the absolute key takeaways they need to know?
I would enthusiastically boil it down to 4 main actionable points.
Hit me. Let's go through them.
Number 1, mechanism deeply matters, but often not in the way you initially think.
Elaborate on that.
We used to overly simplify it. We thought dopamine increases flow, norepinephrine tightly decreases flow. SOAP firmly showed us that norepinephrine's reliable direct action is far more physiologically sound than dopamine's indirect neurotransmitter depleting action.
Yeah.
especially in profound septic shock. Do not ask an empty physiological tank to run a failing pump.
Love that. Okay, what is number 2?
Number 2, safety is a hard primary clinical outcome.
Yes.
Even if the primary mortality p-value was 0.10, the arrhythmia p-value was astronomically significant at less than 0.001. A drug that forcibly doubles the rate of severe cardiac complications is simply an inferior drug. We practice medicine to actively help patients heal, not just to theoretically keep them barely alive. Actively avoiding new-onset atrial fibrillation in the ICU is a massive, highly valid clinical goal.
Could not agree more. Number 3.
Number 3 is the cardiogenic lesson.
Right.
While the pure statistics are undeniably messy regarding that specific interaction test we talked about, the overall clinical signal is crystal clear. Dopamine is downright dangerous for a critically failing heart. It massively increases myocardial oxygen demand in a completely supply-limited state. Norepinephrine is definitively the safer choice to support the failing heart, flying completely contrary to decades of prior medical dogma.
And finally, number 4.
Historical context is vital. This trial was the absolute pivot point in critical care. It fundamentally shifted the burden of proof.
How so?
Well, before 2010, you really had to strongly justify to your attending why you were reaching for norepinephrine first. After 2010, you had to forcefully justify why you were inappropriately using dopamine.
And honestly, 16 years later, I literally cannot think of a single good clinical justification for starting a dopamine drip.
There really isn't one in modern practice. Maybe, perhaps, in a severely resource-limited setting somewhere where you literally don't have electronic infusion pumps, because historically dopamine can be gravity dripped a bit easier. But even then, it's a massive stretch.
It's a relic. It belongs in the medical museum right alongside the mass trousers and the Swan-Ganz catheter.
Well, actually, the Swan is making a bit of a weird comeback lately, but that is definitely a deep dive for a totally different day.
Fair enough. Let's definitely not open the Swan-Ganz can of worms today.
Yeah, we don't have time for that.
But I do want to leave you, the listener, with one lingering provocative thought that still nags at me when I read this paper. The fluid issue.
Ah, the 1 liter problem.
Right. SOAP2 was an incredibly landmark trial. It was beautifully designed for its era, but it was completely a product of its specific time. If we hypothetically ran SOAP our third today, using our modern fluid resuscitation protocols, aggressively giving 3 or 4 liters of crystalloid up front, would the final results be drastically different?
It is a truly fascinating counterfactual to think about. If those patients were actually fully volume replete, maybe the required dopamine dose wouldn't have needed to be pushed nearly so high to get a pressure.
Right.
And if the dose was lower, maybe that horrific arrhythmia signal would have been significantly lower too.
Or conversely, maybe norepinephrine would have won by an even larger statistically significant mortality margin right out of the gate, because we wouldn't be constantly fighting underlying hypovolemia. We will simply never know.
We won't. Nobody is ever going to ethically fund or run that trial again. But it powerfully reminds us that the standard of care is always a moving target. The baseline control arm of 2010 is absolutely not the baseline control arm of 2026.
Science is a rigorous process, not a final destination.
Beautifully put.
So, to the medical students who enthusiastically requested this deep dive, I really hope this gives you the exact clinical ammunition you need. Tomorrow, on rounds, when the attending casually asks, why norepinephrine, don't just lazily say, because the hospital protocol says so.
Please don't say that.
Instead, look them in the eye and say, because the SOAP2 trial definitively showed us that dopamine is a dangerous arrhythmia machine that offers zero mortality benefit, entirely fails to protect the kidneys, and actively harms our cardiogenic shock patients.
Drop the mic and walk out of the ICU.
Exactly. Thank you so much for joining us on this fascinating trip back to 2010.
It is always a huge pleasure to dust off these absolute classics.
If you, the listener, have another historical landmark trial you desperately want us to cover, maybe the original Rivers Early Goal-Directed Therapy trial, or perhaps the original ARDS-NET low tidal volume study, please send us a message. We absolutely love digging deeply into the archives.
And remember to always carefully check your patient's actual fluid responsiveness.
Until next time.
Thank you for spending your time with PRISM Rounds. If this episode helped you think through the paper or offered something practical for the bedside, I'd be grateful if you'd like, follow/subscribe, and share it with a colleague. It's the simplest way to help this resource reach other busy clinicians and learners. I'm also trying to make the podcast better with every episode. Please leave a comment with what you found most useful, what felt unclear or too long, and what topics or papers you'd like covered next. If there's anything I can do to improve pacing, structure, level of detail, or audio quality, I genuinely welcome the feedback. Thanks again for listening, and take care. Educational use only. This is not medical advice.